next speaker is Stephen Waldo from the University of Colorado, who's going to be speaking to us about DCB, when, and why.
All right. First, I'd like to thank the organizers for inviting me and also putting on a fantastic meeting. All right, first my disclosures. I receive unrelated research support to the Denver Research Institute from ABiomed, Cardiovascular Systems, and Merck Pharmaceuticals. As was alluded to in the previous talk, the optimal endovascular strategy for the treatment of FEMPOP disease is certainly evolving. Initial studies published over a decade ago demonstrated that self-expanding nitinol stents had a significant reduction in the restenosis rate at 1 year, 50%, compared to standard balloon angioplasty. However, observational studies have subsequently raised concerns regarding the risks of stent fracture and restenosis due to the unique mechanical forces that are present in this region. An observational cohort published a decade ago that included 100 patients treated with self-expanding nitinol stents demonstrated that stent fractures were present in approximately 35% of them, though the plurality of these were 1 or 2 stent shunts that may or may not have been clinically relevant. Regardless, those patients in this cohort that did have stent fractures had a significantly lower primary patency rate at 1 year, approaching 50%. With this in mind, the development of paclitaxel-based drug-eluting stents and balloons represents another evolution in the treatment of peripheral artery disease. There is excellent outcome data for drug-eluting stents, as was presented in the previous talk, up to 5 years. The data on this slide shows that drug-eluting stents have a primary patency rate of approximately 75% at 2 years of follow-up. Interestingly, this is significantly better than patients that were treated with angioplasty alone or angioplasty with provisional bare metal or drug-eluting stents. As you know, recent randomized clinical trials have also demonstrated that angioplasty with a drug-coated balloon is superior to standard angioplasty. One of the first trials was published 2 years ago and randomized over 400 patients with claudication or ischemic rest pain to receive treatment with a drug-coated balloon or standard angioplasty. The lesions in this trial were moderate in length, with a median length of about 80 millimeters, and only 21% were chronic total occlusions. The data at 1 year demonstrated that treatment with a drug-coated balloon was associated with a significantly increased primary patency rate. Another randomized trial utilizing a different paclitaxel-coated balloon demonstrated similar findings at 1 year, where the freedom from clinically driven TLR was 98% among those treated with a drug-coated balloon, compared to 79% for those treated with angioplasty alone. The same cohort has now been followed for 2 and 3 years, although I only present the 2-year data, demonstrating a primary patency of 79% among those treated with a drug-coated balloon and freedom from TLR at 91%. Additional data suggested that the treatment with drug-coated balloons may achieve these same results in more complex lesions. As I alluded to, the majority of patients that were enrolled in these clinical trials had relatively moderate length lesions ranging from 60 to 80 millimeters. The rate of calcification and chronic total occlusions was also relatively low. With this in mind, an observational cohort was developed that included over 100 patients with more complex FEMPOP disease. The patients in this cohort had a median lesion length of 251 millimeters, 65% of the lesions were extensively calcified, and 50% were chronic total occlusions. The primary strategy was drug-coated balloon for the majority of these patients, and only 10% required bailout stenting. With that in mind, the primary patency at 1 year was still approximately 80%. This same cohort has now been followed for 24 months, showing similar results with an overall primary patency rate of 72%. The authors stratified these results further based on the initial lesion characteristics that were treated, showing patients with non-occlusive lesions or very long lesions did significantly better. Regardless, the overall patency rate, regardless of the lesion characteristics, was considerably higher than would be expected and similar to many stent-based strategies. Further studies have focused on the use of drug-coated balloons as a primary strategy in extensively calcified lesions. This data is from our institution, in which approximately 80 patients with 139 calcified lesions with a median lesion length of 135 millimeters were treated with a primary drug-coated balloon strategy. We stratified the patients based on the treatment with concomitant orbital atherectomy, and it was determined that orbital atherectomy was associated with a significant reduction in the rate of bailout stenting, 18%. In both patient populations, however, the primary patency was similar to that demonstrated in the previous clinical trials, 78 to 80%. Moving on, in-stent restenosis. Additional data has demonstrated that efficacy for drug-coated balloons in restenosis is similar to that and de novo lesions. The FAIR trial randomized over 100 patients with in-stent restenosis in the FEMPOP region to receive treatment with a drug-coated balloon or standard balloon angioplasty. The median length of restenosis in this trial was approximately 80 millimeters, and the primary results are shown on this slide. The freedom from target lesion revascularization was 91% among those treated with drug-coated balloons and 53% among those treated with standard balloon angioplasty. Now, there are several non-clinical disadvantages to using a primary drug-coated balloon strategy. Prolonged inflation times are often necessary in order to ensure adequate transfer of paclitaxel to the vascular wall, particularly in longer lesions where multiple overlapping balloon inflations are required. Drug-coated balloons may also cost more. With that in mind, a cost-effectiveness analysis was performed a year ago based on the IMPACT trial that I presented earlier in the slides. The upfront cost of using drug-coated balloons is approximately $1,100 more than standard angioplasty within this trial. However, the increased rate of target lesion revascularization among those that received standard angioplasty increased the overall cost over 2 years by an additional $1,200, so that it was a wash in the end, and drug-coated balloons were deemed cost-effective. So with this data in mind, when do I use drug-coated balloons for FEMPOP disease? Drug-coated balloons are my primary strategy for the majority of de novo patients with FEMPOP disease. I also use drug-coated balloons in areas of restenosis, usually in combination with laser atherectomy. In all cases, I will use stents as a bailout strategy when there are flow-limiting dissections or dissections that I think that there's a pressure gradient to cross. That occurs in about 10 to 25% of the patients that we see in our lab. Why do I follow this strategy? Inevitably, a reasonable proportion of the patients that we treat return to the lab with recurrent disease. By the data that I presented, this would occur 10 to 20% of the time over several years of follow-up. I find that it's easier to approach these patients the second or third time if there's not a stent present. I think it's much easier to avoid the complications of a stent by not placing one than to rectify them once it is in place. And with that, we advocate a strategy of leaving nothing behind for the majority of our patients. With that, I'm happy to take any questions at the conclusion of the panel. Thank you.